Small bowel obstruction is finally something totally different. This is a blockage in your bowel. This will lead to proximal bowel distension. And so let's see what that looks like. Let's say you have a food bolus that's coming through your bowel. Let's say there's some obstruction here for whatever reason. What's going to happen is that food will back up proximal to that obstruction, and then it'll actually distend the bowel. The danger of that is that it could obviously perforate. So the number one cause of this are adhesions from a prior surgery. This can also happen in the setting of hernias. The third most common cause is cancer. And a rarer cause, but something that they do test sometimes, is intussusception. Let's go over each of these causes in the order of likelihood. So the most common cause in somebody who's, especially in somebody who's had surgery, are adhesions. So if you imagine you've had surgery in the past and you have all this inflammation before, that can develop into this scar tissue. And that scar tissue can actually attach to your bowel and start to move it around. And so imagine if that moves and constricts a portion of your bowel, it's too skinny there, and that can cause an obstruction. Hernias, imagine a portion of your bowel gets pushed through an area that it's not supposed to get pushed through. So what can happen here is that this area is now constricted right here where it pushed through. It can have an external force compressing it, pushing it down, and you can get an obstruction in this way. Cancer is pretty easy to understand. If you have a mass that's obstructing most of your lumen, you can get a small bowel obstruction. One thing I want to note is when we talk about colon cancer, we'll mention this. It's that obstruction is more common in left-sided tumors, whereas the right-sided tumors more often present with bleeding symptoms. And last thing I want to mention is intussusception. Intussusception is where one portion of your bowel gets pushed into another portion. So that would look something like this portion getting pushed into this one, might look something like this. And obviously, because the lumen is decreased, you can get a small bowel obstruction in this case too. So how does this present? Usually presents as nausea and vomiting. You'll get constipation. You'll get a lack of flatulence, which is an important indicator that something may be blocked. You'll also get bloating and abdominal distension. On imaging, you're going to see multiple small bowel dilations on X-ray, and you might see something called air fluid levels on CT. So on the X-ray to the left, it should be pretty obvious that these bowels are very, very dilated. And on the CT imaging, there's a few different examples of air fluid levels. So you can see that right here. That's suggestive of a small bowel obstruction. So to treat this, there's a few things you can do. The first thing you do, if nothing's perforated yet, you usually wait. You can drain what's in the stomach through nasogastric suction. You want to keep them NPO, which just means nil per os means you don't want to give them anything by mouth because you'll just make the obstruction worse. And you want to control their pain. And then if their symptoms worsen or just aren't getting better, or if the bowel perforates, which you should know about pretty quickly because they'll become very, very sick very quickly, then you'll want to involve surgery. Next, we're going to talk about some of the blood-related conditions, acute and chronic mesenteric ischemia. These are kind of like our heart attacks and our angina of the intestines. So acute mesenteric ischemia is like an acute heart attack, basically. So it's an intestinal heart attack. It's usually caused by embolic occlusion of the SMA, and it leads to small bowel ischemia and necrosis. So I showed this earlier. Basically, what happens here is that you have some sort of clot that's going to break off and travel down your aorta, and sometimes it'll reach your GI tract. So the first structure it'll reach is the celiac trunk, but because the celiac trunk is so branches off the aorta at such an extreme angle, it usually avoids getting a clot lodged into it. The problem with the SMA is it's pretty straightforward. It's not that extreme of an angle, so you can get a clot, and this would potentially cause acute mesenteric ischemia. You're going to see this in the same people you'll see regular heart attacks with, right? And so these are called vasculopaths. So it's going to be people with a ton of risk factors. They might be smoker, obese, type 2 diabetes. I wrote obesity twice for some reason. But anybody who has a ton of risk factors for a stroke or for peripheral artery disease or heart attack, those are the same people who I want you to consider may have acute or chronic mesenteric ischemia. This will present with severe abdominal pain, and you're going to see something called current jelly stools, which I talk about later. Just so you know, for now, current jelly stools I talk about in the intussusception section later on. Basically, it looks like blood mixed with mucus. And the reason why that's happening is that you have cells that are actively dying off, and your enterocytes that are connected to your lumen release all that mucus that they've had stored inside of them, in addition to blood. And so that's why you get these things that are described as current jelly stools. You'll have this classic pain out of proportion where somebody is in writhing pain and then you do a physical exam and everything's normal. I don't want you to be reassured by that normal physical exam because it could easily mean they have this condition. You'll see decreased bowel sounds. And what you have to do, you have to treat it with emergent surgery. Emergent is important to realize. This condition is extremely deadly. Like, just like we treat heart attacks very early, you have to treat this intestinal heart attack very early. The earlier, the better. So chronic mesenteric ischemia is more like intestinal angina, where you have symptoms when you're doing some activity, but then the symptoms go away at rest. So it's reversible. Nothing's dying yet. Nothing's necrotic. You get a little bit of ischemia that can cause pain, but then that ischemia starts to go away. It's usually postprandial, and this should make sense because when you eat food, that's when your intestines require more blood flow. That's when they're technically working the hardest, is after you've eaten. So this is our acute mesenteric ischemia, which showed a heart attack. If we compare this one, which is a complete blockage causing necrosis, we'll compare it to chronic mesenteric ischemia, which isn't necessarily a complete blockage. Imagine you have like a plaque, a cholesterol plaque in the way, and during normal times, there's enough blood supply to get through and supply the distal tissues without a problem. But if we eat, the problem is that we require more blood flow to these regions. So we're really trying to push a lot of blood through this small area. And what's going to happen is that the distal regions of this are not getting perfused enough. So they kind of get a little ischemic, and that can cause some pain. The classic patient is the exact same patient you'll see in acute mesenteric ischemia. That's your vasculopath who has all the same symptoms. The presentation of this one is that you're going to see somebody who has abdominal pain after meals, like we discussed. You also might see somebody who has significant weight loss. And if you probe as to why they've been losing weight, they'll tell you that they just haven't been eating as much because it's too painful. You treat this with angioplasty, which is where you can put a stent in and kind of open up that area that had that plaque to avoid these symptoms. I just want to point out here, I highlighted these specifically. Whenever you see somebody with like abdominal pain and significant weight loss, it's very easy to think cancer. And I think on a test, most of the time, you'd probably be right. I just want you to remember that if the pain is postprandial and they give you a lot of these other risk factors, they tell you that this person has hypertension, diabetes, they've had a stroke, they've had a heart attack, I want you to consider that it might actually be this chronic mesenteric ischemia. So keep that on your differential. The last thing we'll talk about for adult conditions is the carcinoid tumor and carcinoid syndrome. So the carcinoid tumor is a type of tumor that secretes serotonin. It's usually located in the small intestine. It could also be located in the stomach, the rectum, or the appendix. And how this presents, the tough thing about carcinoid tumors is that they're going to be asymptomatic if they're just within their GI tract, but if they've spread somewhere else, they can get something called carcinoid syndrome. So let's talk about what carcinoid syndrome looks like. Carcinoid syndrome is a syndrome that occurs because of widespread release of serotonin into your blood. And a question you're probably asking yourself is, why don't all carcinoid tumors cause carcinoid syndrome? Well, the good news is that we have a few of our organs that can metabolize serotonin and prevent serotonin from being active in our bloodstream, namely in our liver and lungs. So if this is our bloodstream, every GI tract organ will drain into our portal system. So if we have, here's our carcinoid tumor, it's going to secrete serotonin. That's going to go into our portal circulation the vast majority of the time. And when it encounters the liver is able to metabolize it into an inactive compound called 5-HIAA, and this can be excreted in the kidneys, and you'll never have carcinoid syndrome. The thing is, what if you had a metastatic lesion on your liver or distal to your liver? What's going to happen here is that this can secrete serotonin, and the liver can no longer metabolize it because it's distal to the liver. So this can travel through your hepatic vein into your IVC and go into your right heart. And from the right heart, you'll go into your lungs. From the lungs, you'll go to your left heart. Remember, the liver and the lungs contain enzymes. So once it reaches the lungs, it'll also be metabolized, which can be excreted, which will spare your left heart from symptoms. So when we talk about the presentation, there's a common mnemonic called BFDR. Our B is for bronchospasm, our F is for flushing, our D is for secretory diarrhea, and our R is for right-sided heart defects. And again, if we talk about here, notice that our lungs are preventing serotonin from reaching our left heart and causing damage to the left heart, so you'll only see right-sided defects. You'll also, something they sometimes test is the fact that carcinoid syndrome can cause niacin deficiency, which is vitamin B3. Niacin deficiency, a good mnemonic for niacin deficiency is our 3Ds. You have dermatitis, dementia, and death. And why does niacin deficiency happen? What's going on here is that tryptophan can be broken down into a few things, one of which is serotonin. Serotonin's actual name is 5-hydroxytryptophan. So you can see that tryptophan serotonin is a byproduct of tryptophan. Tryptophan can also be used in the formation of niacin. The problem with carcinoid syndrome is that we're producing so much serotonin that there's not enough tryptophan left to produce niacin. So you can get this niacin deficiency, which again can present with that dermatitis, dementia, and death. How do you diagnose carcinoid tumor? Any neuroendocrine tumor would have elevated chromogranin A levels. That's one way. But the way that they usually test on a test is they like to do elevated 5-HIAA levels in the urine. Recall from here that all of the metabolites from the liver and the lung metabolism will end up going into the kidneys as 5-HIAA. So to detect this, especially on a test, you should always be picking this as your diagnostic criteria for carcinoid syndrome. If you did biopsy it somehow, you'd find out that the tumor cells are chromogranin and synaptophysin positive. I think that's pretty low yield. As long as you remember the 5-HIAA, you should be set on a test. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.